will be working also.
This one for the second one, right? Second and fourth.
Is it on? Yeah.
Yeah.
It's working.
Okay.
Okay.
Okay, thank you. So good afternoon, everyone. I'm Dr. Maryam Mahmood, consultant OB-GYN from Salmania. Today I'll just give you a quick review about the gynecological cancers. We know that the gynecological cancers involving the uterine cancer, which is the same as endometrial cancer, the ovarian cancer, the cervical cancer, the vulval cancer, the vaginal cancer, and at the end, the molar pregnancy or the gestational trophoblast neoplasia that comes with the after the placenta. I mean, as a tumor of the placenta. Okay. Now, the gynecological, the most common is the uterine cancer. Okay, I'll go through one by one just to see the main things about them. The ovarian cancers, of course, it can be benign or can be malignant. Okay, it depends on the type. Now, unfortunately, if it is malignant, most of the cases discovered late, when it is like in the late stage, in the third or fourth stage, and has a poor prognosis most of the cases. But if it is discovered early, when it's only in the ovary, didn't go outside the pelvis, the prognosis is better. Now, as I said before, these are the gynecological malignancies. Regarding the ovarian cancers, it comes more in the postmenopausal ladies, most common. So, but still, you can see still people who are young getting ovarian cancers, but very rare. The median age, or the most common, in the 61 years or the postmenopausal. The risk factors who are at risk: the nulliparity, the early menarche, those who are using the combined oral contraceptives will give them protective protections for ovarian cancers, will not be risk factors. Okay. Now, of course, there is no specific cause for the ovarian cancer, but there are risk factors, as I said. The main risk factors are having a hereditary mutation. When you have a BRCA or BRCA2 or 1 runs in the family, with the family having this genetic mutation, they will have the risk of developing in the futures ovarian cancers and even breast cancer. Okay. Now, regarding this, 5 to 10% of the ovarian cancer in general caused by the familial or the hereditary factors. The BRCA, it's like gives maybe 40 to 60% risk factors to have ovarian cancers. BRCA2 gives less, like 20-40%. The classification, we have three big classifications, or the major types of ovarian cancers that are the epithelial, the germ cells, and the sex cord. There are three groups, but each group have also a different subtypes. Okay, like for example, the epithelial, it has the serous, mucinous, endometrioid, clear cells, Brenner's, borderline tumors. So it depends on the pathological type. Okay. Now we have the other group is the sex cord. The sex cords are hormonal dependent, so they secrete hormones. So the patients, for these patients who are having sex cord tumors, they present more early. They will have for example, symptoms for that earlier than the epithelial types. So if they have granulosa, they will have normal vaginal bleeding. If they have Sertoli Leydig cells, they will have high testosterone, so will have virilization and anterior baldness, muscular changing in the voice, all the symptoms of for male. These are mainly from Sertoli Leydig cells. Okay, now the germ cells of tumors is the primitive germ cells comes from ectoderm, endoderm, mesoderm. These are three the tumors comes from. So they are more like embryonic types. So they also secretes like tumor. We say they have a tumor marker for that. Okay. Now, the most common is the dysgerminoma. We have also the endodermal sinus tumor, the embryonal carcinoma, immature teratoma. These are the same as dermoid. When you say dermoid, it's mature teratoma, the benign form. Okay, because each ovarian has benign and malignant form. The epithelial has benign or malignant form. So the immature teratoma is malignant form of the dermoid. So you say dermoid is the same as mature teratoma, is the same. Okay, but just two names for the same thing. Okay, and non-gestational choriocarcinoma, this is very rare. It secretes more beta-HCG. Okay, now the ovarian cancer diagnosis, as I said at the beginning, it's most of them are diagnosed very late. So the symptoms are vague. It's not like specific for the ovarian. So it can be like abdominal pain, bloating, diastasis, like frequent urination, feeling full. Whenever she eats anything, she will feel full. So it's more like GI problem, but it's not GI. It's just when the disease comes late, discovered late, it goes to the metastasis to the abdomen, to the omentum, and cause these symptoms. Most of the cases discovered by the GI, by the consultant of gastroenterologist. They referred to us. They said, okay, this patient, she came to me with pain in the abdomen and bloating, feeling full very fast, or gastric upset. So we did ultrasound and we found there is a cyst or there is an ovarian tumor. Okay. Now the workup, ovarian cancers, as I said, has a tumor marker. So not all of them, but most of them have a tumor marker. We can do like CA125, beta-HCG, alpha-fetoprotein, depends on the type. Like the epithelial type, we do CA125. It will be high in the epithelial types, okay? The alpha-fetoprotein, where you think it will be high? In which group? Yeah, so it will be in the germ cells with the endodermal sinus tumors, okay? LDH with dysgerminoma also, it can be high. There is, like for granulosa, I think it's increasing a lot of estrogen, but we cannot, like, it is not specific to see the level of the estradiol and check and decide whether it's a tumor or not. No, but there is a special another tumor marker which is inhibin also for the granulosa cell tumor. So of course we do the tumor markers in a blood investigation, and then we do ultrasound. We discover there is an ovarian tumor or an ovarian cyst, and then if there is any suspicious, we can do for metastasis, we can do CT scan and MRI. Okay, so these are the workup. Now the staging, it comes, it can be the first stage in the one ovary, then second stage will be in the second ovary. It can go to the tube in the second stage, or it can go to the infiltration to the bladder. That is really starting to advance, and then going to the abdomen where it goes to the omentum. That's stage 3. Stage 4 also goes to the other pleural effusion, like to the lung, to the spleen, and so on. Now, the ovarian tumors, in general, the surgery is the treatment. Unless if it is advanced, we do maybe chemotherapy. Okay. Now, doing a surgery, it depends on the tumor. Is the early stage, we do staging surgery. We do something called fertility sparing surgery. We if it is in the one ovary only, so we can do salpingo-oophorectomy, removing only the ovary and the tube, and then take a biopsy. But we don't have to remove the uterus in all the time. Unless patient is postmenopausal, finish her family, you can do a hysterectomy. So the surgery involving total abdominal hysterectomy, bilateral salpingo-oophorectomy, removing the tubes and the ovary, omentum, peritoneal biopsy, pelvic and para-aortic lymphadenectomy. Okay, that is in the early stage for postmenopausal. If it is early stage and for a young lady who didn't finish her family, we can do something called unilateral salpingo-oophorectomy and staging surgery, of course. She can have only one side, the other side will be preserved, the other ovary she can get in the future pregnant with the other side, if she remains disease-free, of course, in the future. Okay. Now, the adjuvant therapy is always chemotherapy. The advanced stage, as I said, it's like debulking or chemotherapy. It depends. Okay, the uterine cancers, these are a good prognosis cancers. They presented very early. Patient will have with abnormal uterine bleeding most of the time, or postmenopausal bleeding if she like stopped her period for a long time and then she had a postmenopausal bleeding. The uterine cancer, the median age also in the postmenopause, most of the time in the old age, like in the 60 years. Okay, and as I said at the beginning, the patient will present very early with abnormal uterine bleeding. And the risk factors for this, there's no direct cause, but the risk factors are if patient is having a lot of estrogen. Either it is endogenous from inside, the body is producing, or from outside, if she's taking any hormonal replacement therapy or estrogen. Okay, now the obesity is one of the producer for estrogen because of that. ليش عندهم الأوبيز عندهم estrogen وايد؟ من وين يطلع لهم؟ From where it comes? Estrogen for the obese patient. Adipose tissue, huh? No, it's from adipose tissue. Adipose tissue شو يطلع؟ Hmm? Yeah, it changes and it produce more estrogen from the adipose tissue. Okay? Huh? في الادipose tissue في الفات. Okay? So she will produce more from the fat, more estrogen. Okay? And of course, early menarche, late menopause, nulliparity, chronic anovulation also will be a risk of uterine cancers. Of course, who are having chronic anovulation? Men? Polycystic ovarian cysts, if they are in the future having a risk for uterine cancers. Those who are taking tamoxifen, it's like a type of hormonal they give for the breast cancers to prevent the recurrence of breast cancer. It has an estrogenic effect on the uterine, anti-estrogenic effect on the breast. So they give it for the breast cancer, but unfortunately it can cause sometimes cancer in the uterus. Okay. The patient, of course, of having a family genetic mutation also runs in the family, like HNBCC, the same as Lynch 2 syndrome. Having multiple cancers, like they will have a mix of cancers runs in the family, like they're more prone to like have stomach cancers, kidney cancer, bowel, colon, uterine, even ovary also. A lot of many types. So these families are having most likely Lynch 2 syndrome. They are of course at risk of uterine cancer. Okay, as I said, oral contraceptives also preventive. Oral contraceptives maybe play a role in the preventions of gynecological cancers, except for the breast cancers. It can be a risk factors, but preventive for the oral and for the uterine and for the ovarian. Those who are having hyperplasia of the uterus also, again the polycystic will have more estrogen, chronic anovulation, and they will have sort of uterine hyperplasia. That's also will be considered as a precancerous lesion for the uterine cancers. The workup, again, pelvic ultrasound, pap smear, and endometrial sampling, or DNC. So you know that we have to take a biopsy to see which type of tumors she's having. Okay, so patient presented with abnormal uterine bleeding, a part of the investigation beside the pelvic ultrasound, the pap smear, we do something as an office procedure. We take a specimen from inside the uterine cavity. It's called endometrial sampling. In case we cannot enter the cervix stenosed or something, we do dilatation and curettage and regional anesthesia to diagnose, see which pathology we have. Okay, now the pathologic uterine cancer, we have two major types, epithelial and mesenchymal. And the direct, always like direct invasion, the spread, the behavior of the disease is always spread directly, like extend directly or going to the lymph nodes. Uterine cancers, we have, like, they divided. At the beginning, they divide them according to the types, اللي هو epithelial, mesenchymal, and then they said no, there is two types, which is one is considered as a good prognosis, and the other one, type 2, considered a poor prognosis. The good prognosis who are having endometrioid adenocarcinoma, this is a one type of the epithelial type, usually good prognosis, and this is comes in the polycystic ovarian syndrome who are having estrogen, a lot of estrogen. And the type 2 is less like, poor prognosis. It's include the other type of uterine cancers, serous or the undifferentiated one. Now the stages, as I said, it's because locally extends, so it goes to the myometrium, to the endometrium, then the myometrium, then the serosa, and it goes down to the cervix and goes to the tube, and then to the ovary, and then goes into the lymph nodes. So it depends on the stage. It's always also treatment of the uterine is also surgery, like the ovarian, and we do TAH, total abdominal hysterectomy, bilateral salpingio-oophorectomy. Okay, as I said, it's always total abdominal hysterectomy. So you don't leave the uterus here because it has the tumors. It's not like the ovary. The ovary, you remove the ovary and you leave the other ovary. And you leave the uterus, of course, if it is early stage. But for the uterus, you always do a total abdominal hysterectomy, bilateral salpingio-oophorectomy, and then you take biopsies from the other lymph nodes, pelvic, para-aortic. The adjuvant therapy is, for the uterine cancer, most of the cases are adjuvant radiation. And for the ovarian, we said chemo, but for the uterine, it's always most of the time radiation, and if it is advanced, chemotherapy. The uterine cancers, the other types is the mesenchymal, sarcoma is the other types. Okay, these are poor prognosis, and it's only very rare, 5% of the uterine cancers, and the treatment is also surgery, hysterectomy, bilateral salpingio-oophorectomy, and then chemotherapy. Cervical cancers, it comes as a precancerous lesions, and then develop into cancers. Okay, so it's maybe a microscopic disease, and then becoming more macroscopic, where you can see it when you examine the patient. So it starts with the pre-invasive disease. The pre-invasive disease, we have CIN1, CIN2, CIN3. These are diagnosed usually after doing colposcopy and biopsy, because usually what we do for screening for the cervical cancer, we do pap smear, right? Okay, so if pap smear is not normal, we go for the biopsy, which is done with the colposcopy. Okay, and then the colposcopy will tell us the biopsy whether it is a CIN1, CIN2, or CIN3, or is a cancer even. Okay, and then you decide the treatment. If it is early stage, you don't have to go and remove the uterus, the whole thing, or the cervix. You can do cone biopsy if it is very early stage, microscopic. So this is usually what we do. We do pap smear, and then if it is abnormal, we do a colposcopy directed biopsy. Okay, the mean age of the cervical cancer is 52, a little bit younger. The pathogenesis, 99% is the HPV. So the cause we know for that. It's not like, of course, there are risk factors. There are risk factors of having multiple sexual partners early, starting sexual life very early, immunosuppressive. All of this are having risk factors. But the main cause is the HPV, the high risk type of the HPV. Which one is, you think? 16 and 18. Okay, there are others also, but 16 and 18 is the more aggressive and the most common. The symptoms of the cervical cancer is postcoital bleeding. Okay, now this is the HPV. It's a sexually transmitted. This is the only cancer that is sexually transmitted. Okay, and it has a vaccine, of course. So the only cancer that has a vaccine also. So Gardasil 9 is covering 31, 33. sorry, 16, 18, 31, 33, 45, 52, 58, 56. So that's is really prevention. It gives up to 90% preventions of the cervical cancers if you take this vaccine. So I'm encouraging people to take it. If still people who are young, and I know that they have it in our national program for students who are grade 11, year 11 and 12, and most of the Gulf countries have started putting it in the vaccination program, and now we have it also in the market for those who are after that, like you can take it up to age of 45. So this HPV vaccine is the first one was covering only 16 and 18. Then they have the Gardasil, which has covering four, preventing against four types, 6 and 11, 16 and 18. 6 and 11 cause what? Benign or low risk, you consider, causing most of the time warts, اللي هو condyloma acuminata. Okay, and the Gardasil 9 is the new one where they're giving its cover 16, 18, 31, 33, 45, 52, and 58. Cervical cancer, the pathology, it's either adenocarcinoma or squamous cell carcinoma. Okay, and both of them are caused by HPV. The cancer of the cervix extend locally. It's like the uterine also. So it goes to the around the uterus and around the cervix where the parametria is, and then they go to the uterus and extend locally. So the cervical cancer, because it starts in the poor countries, so they didn't have an MRI or CT scan at the beginning to do and see the stage or where exactly the disease. So they were depending on the examination of the patients, BV examination, vaginal examination. They see where the stage, or which stage 1 or stage 2 or stage 3, according to where the disease is. So if it is only the cervix, stage 1, and if it's going to the parametria, stage 2. Okay, going to the pelvic wall, stage 3, for example. So it's like that's why they said clinically staging, because they didn't have this MRI and CT scan, so they were depending on the clinical examination. And then if you have a doubt that the bladder is involved or the rectum is involved, so you do cystoscopy, proctoscopy as a part of the workup, of course. Then CT, MRI, of course, if you have the facilities. Now this is the staging, as I said, it's locally extend. And the treatment is, if it is early stage, when the disease is small, less than 2 centimeter, and stage 1, most of the time we do hysterectomy. And a special type of hysterectomy is radical hysterectomy, where we take more from the, vagina, the lateral to the cervix, from the parametria exactly. So we take more from this, and it's called a radical hysterectomy. And then if it is advanced, it's there's no rule of surgery, so you give only chemo and radiation. So in summary, the endometrial carcinoma, endometrial adenocarcinoma is the most common cancers in the females, after the breast cancer, of course. Okay, all gynecological cancers are staged surgically except the cervical cancers. They depends on the vaginal on the clinical examination. Cervical cancer associated with the chronic infections by the HPV. Ovarian cancer is usually presenting late, treated with surgery and followed by chemotherapy. The endometrial cancer has the better prognosis and diagnosed by the biopsy of the endometrium, which can be taken as an officer procedures by endometrial sampling with the pap smear, or taking the patient to the theater doing DNC or dilatation and curettage. Thank you very much. Any question? Okay, it's clear.